Well friends, today we will see pancreas. It is said that God has put pancreas at the back of all organs because no surgeon should mess with it easily. But mind well friends, but the same pancreas when gets inflamed can cause inflammation of all the organs which are lying in front of it. So we'll see what is acute pancreatitis. What are the causes of acute pancreatitis? Biliary tract disease, basically gallstones or stones which are migrating from gallbladder to the common bile duct. This is the most common cause of acute pancreatitis in present scenario. Followed by biliary tract stones, it is alcohol. Then comes hyperlipidemia. Then comes hereditary hypercalcemia. Then is the trauma. Amongst trauma, we have got external trauma by road traffic accident or by assault. Then we have got surgical trauma after pancreatomy or various pancreatic resections. Then we have got endoscopic retrograde cholangiopancreatography, that is ERCP. It is an interventional procedure which may lead to pancreatitis when it is done for some other reason. We have got ischemia, which may be due to hypoperfusion, say following a severe septic shock, or other embolic conditions which may cause various types of hypoperfusion, or we may get vasculitis which may be of autoimmune in nature. Pancreatic duct obstruction may be because of various neoplasms or pancreatic divisum or ampullary and duodenal lesions which may cause pancreatic duct obstruction. These all conditions may lead to the acute pancreatitis. Among infections, we have got mumps which may follow pancreatitis, Coxsackie B virus infection, cytomegalovirus infection, cryptococcus infection, or some venoms by some scorpion bites can cause acute pancreatitis, or the cause may not be known, which is called as idiopathic condition. There are some drugs. So friends, you may be asked various questions on these etiologies. Which of the following may cause pancreatitis? So all amongst etiologies that we saw, they may be adding some other factors which may not be causing pancreatitis. So mind well, you have to go through all these etiologies very thoroughly because there may be various types of permutation combination of MCQ questions based on the etiological factors. So many of the questions are asked on drugs. Which of the following drugs does not cause acute pancreatitis? So we'll go through the list of drugs. These are thiazide diuretics which may cause pancreatitis. Then we have got furosemide, estrogens, azathioprine, L-asparginase, 6-mercaptopurine, methyl-dopa, the sulfonamides, tetracycline, pentamidine, procainamide, nitrofurantoin, valproic acid, and acetylcholinesterase inhibitors which may cause pancreatitis. There may be miscellaneous causes. Hypercalcemia arising from hyperparathyroidism results in both acute and chronic pancreatitis. The mechanism most likely involves hypersecretion and the formation of calcified stones which are intraductally. So when the stones are formed intraductally, they may cause obstruction and acute pancreatitis. So some of these causes, they may be seen in chronic pancreatitis also, because many times chronic pancreatitis is the result of various attacks of acute pancreatitis. We'll see what is the pathophysiology behind acute pancreatitis. Pancreatitis begins with the activation of digestive zymogens inside acinar cells which will cause acinal cell injury. Once the injury occurs, lysosomal hydroxylase, which is cathepsin B, which is known to activate trypsinogen to trypsin in the cell to cause pancreatitis, is released. So it will activate a cascade of reactions and which will lead to the acute pancreatitis. So acute pancreatitis is like an atomic explosion which will cause chain reaction. So we don't know where it will stop. So many times we may see from mild variety to the severe variety of pancreatitis attack. The ultimate severity of acute pancreatitis depends on the extent of systemic inflammatory response as well as several cytokines and chemokines and the receptors that play a critical role in the activation and migration of inflammatory cells to the affected sites. So all these reactions or all these inflammatory mediators will react to the severity of the acute pancreatitis as well as cause systemic response. How do you diagnose acute pancreatitis? Patients will present with severe pain, usually in epigastric region, may be relieved by patient drilling forwards, or it may be precipitated with only nausea and vomiting. So patient may present with only nausea, vomiting, and along with the pain. An episode of acute pancreatic inflammation in a patient with known pancreatitis has the same findings. So it is the same spectrum of symptoms that the patient gets during repeated attacks of acute pancreatitis. Patient will have tachycardia, tachypnea, hypotension and hyperthermia. In some patients, about 1% of them, the blood from the necrotizing pancreatitis may dissect to soft tissues. Pancreas is a retroperitoneal organ, so all the blood which is formed during acute pancreatitis or inflammatory exudates, they will migrate through the retroperitoneum, they will reach the anteroabdominal wall. So they may cause a bluish discoloration around the umbilicus, it is called as Cullen sign, or it may form in the flank which is called as Gray Turner signs. So how do you remember them? It is U for umbilicus and it is same U in Cullen sign. So it is not there in Gray Turner sign. So flanks is Gray Turner. So remember friends, they may be asking various questions. If the patient gets discoloration in the flanks, which of the following signs which is called? So they may confuse you by Cullen's, Gray Turner or other signs. You should be writing the proper answer. Cullen's is for umbilicus and Gray Turner is for flanks. So what are the serum markers? We have got serum amylase concentration, which increases almost immediately with the onset of disease and peaks within several hours. Now we'll see how the trend of amylase changes. So there may be various types of permutation combination of questions depending. They may be giving a clinical scenario and say after 7 days or after 12 days or after 4 days, which is the proper investigation. So depending on the serum markers, we will have to answer the appropriate serum marker. So at the onset of the disease, serum amylase peaks within several hours. So we have got serum amylase which will peak within 5 to 6 hours to its maximum level. It will remain elevated for 48 to 72 hours before returning to normal over 3 to 5 days. So this is the graph of serum amylase, that it will return to normal within 5 days. So this is very important thing. So there is no significant correlation between magnitude of serum amylase elevation and severity of pancreatitis. Hyperamylasemia can occur in a patient with small bowel obstruction, perforated duodenal ulcer or other inflammatory intra-abdominal conditions. So this is not a very specific marker. So in many cases, urinary clearance of pancreatic enzymes from circulation increases during pancreatitis. Therefore, urinary levels may be more sensitive than serum levels. So if you are asked a question, which of the following is more sensitive level to assess, and if amongst them we do not have lipase as the answer, then it's urinary amylase estimation which is more sensitive than serum amylase. So urinary amylase levels remain elevated for several days after serum levels have returned normal. So urinary amylase will give you more chances of diagnosing acute pancreatitis in later stages, even after. So if you are asked question after 10 days, which of the following investigation that will you do? It is urinary amylase, not the serum amylase. So this is how you have to answer depending on the days which have passed after onset of acute pain. Measuring pancreatic specific amylase, which is also called as P amylase, rather than the total amylase. So total amylase which will include all body amylases, which will be also salivary amylase also. So P amylase is the component of total amylase. So if you measure pancreatic amylase, which will make diagnosis more specific. So 88 to 93% of the time, P amylase will be more specifically diagnosing of acute pancreatitis. We have got also serum lipase estimation. As the serum lipase levels remain elevated for longer than total or pancreatic amylase, it is the serum indicator of highest probability of the disease. So this will again, if you have got serum lipase and urinary amylase, both of these answers in your MCQ, then you should have answer lipase. If the lipase is not there, then urinary amylase. So this is how you have to answer the question. Next radiological investigation that we have is the ultrasound. It is the best way to confirm presence of gallstones in the suspected biliary pancreatitis, as it is available bedside and all of the patients which are presenting with acute pancreatitis are quite sick. They may be having hypotension, they may not be fit enough to travel to the CT scan, or they may not be fit enough to undergo ERCP. So all these patients, they can be subjected to the ultrasonography. Next we have got computed tomography scan. It is now the gold standard for detecting and assessing the severity of pancreatitis. In necrotizing pancreatitis, the microcirculation is disrupted. Therefore, the enhancement of the gland on contrast enhanced CT scan is considerably decreased. So where there is necrosis because disruption of the microcirculation, the gland may not get enhanced. So depending on the half of the gland or 1/3 of the gland or 2/3 of the gland which is non-enhancing, you have to grade the severity. So that is important from prognostication point of view. CT scan will also show you air bubbles. So presence of air bubbles on CT scan is indicated of infected necrosis or pancreatic abscess because of presence of gas forming organism. So friends, if you given a clinical scenario in which you have got a patient with acute pancreatitis in its second week of pancreatitis, and the patient will be having fever, race counts, and they will be asking you which of the following investigation you will do. So they will give you MRI, CT scan or MRCP, ERCP or ultrasonography. So you have to pick up as a CT scan as the best choice of investigation to pick up the air. So currently intravenous bolus contrast enhanced CT scan is routinely performed on patients who are suspected of harboring severe pancreatitis, regardless of their Ranson score or APACHE scores. Now we will see how do you assess the severity of pancreatitis. So there are early prognostic signs which can consist of 11 objective parameters. So we have got criteria for acute pancreatitis which is not due to gallstones. So we have got at admission criteria and we have got criteria at 48 hours. So these are called as Ranson's criteria. So you should go through them very well and you should make them well worse with you, because many of the questions are asked on combinations of these Ranson's criteria. So which of the following conditions which you label as severe pancreatitis, they will ask you and they will give you various Ranson's criteria. So if any of the criteria which I am going to mention now is there in answer, it is severe pancreatitis. So you have to pick up the appropriate answer depending on the criteria which is present. So I will also tell you which are the following things which will be asking you to confuse. So at admission, if the patient has got age more than 55 years, his white blood cell count is more than 16,000, blood glucose levels are more than 200 milligrams per deciliter, serum LDH concentration more than 350 international units per liter, serum aspartate transaminase concentration more than 250 units per deciliter. So these are all criteria which will be there if at admission you have to mark one for each point. Then we have got criteria at 48 hours. There will be hematocrit fall more than 10 points, BUN elevation of more than 5 mg per deciliter, serum calcium concentration less than 8, arterial oxygen concentration, that is PO2, less than 60 millimeters of mercury, then base deficit of more than 4 milliequivalents per liter, and estimated fluid sequestration of more than 6 liters. So if amongst these 11 criteria, if you find 2, 4, 6 or 10, you have to grade the severity. So friends, have you noticed that there is no mention of serum amylase in this? So serum amylase is many times added to MCQ pattern to confuse students. So there is no serum amylase in this, or there is no even CT scan, or there is no any radiological investigation in this. So now we'll see criteria for acute gallstone pancreatitis. So we saw 11 criteria for non-gallstone pancreatitis. Now we'll see criteria for acute gallstone pancreatitis. So they differ from them in following way. So we have got at admission, which is age more than 70 years, WBC count more than 18,000, blood glucose levels more than 220 milligrams per deciliter, or serum LDH concentration more than 400 international units per liter, and serum aspartate transaminase concentration more than 250 units per deciliter. So after 48 hours, you again reassess these patients and they will give you what are the criteria. These are hematocrit fall more than 10 points, BUN elevation more than 2 milligrams per deciliter, serum calcium less than 8 milligrams per deciliter. So serum calcium is taken after 48 hours because in severe pancreatitis there will be saponification and which will entrap body's calcium in it, leading to the fall in serum calcium level. So serum calcium is given as an indicator of severe pancreatitis after 48 hours. There will be base deficit which will be more than 5 milliequivalent liters, or there may be base deficit of more than 5 milliequivalents per liter, there will be estimated fluid sequestration of more than 4 liters. So now I show you a chart which will say, so if you have got 0 to 2 number of Ranson sign, the approximate mortality will be 0%. For 3 to 4 numbers, it will be 15%. For 5 to 6 numbers, it will be 50%, and more than 6, there will be 70 to 90%. So if you are given an exam MCQ which will show you Ranson signs of 3 to 4, and they will be asking you, they will give you various, these and these are present, these signs are present, and what will be the approximate mortality. So you have to calculate, you have to give point to each of the signs which are present, and you have to calculate according to this chart. So this is very important chart. You have to go through this chart thoroughly, and you should memorize this chart very well. Next, apart from Ranson's criteria, we have got APACHE-II score, which is acute physiology and chronic health evaluation. So this grading system assesses severity on the basis of quantitative measures of abnormalities of multiple variables, which include vital signs, specific laboratory parameters, which are coupled with the age and chronic health status of the patients. So this is very important criteria. Some of the ICU care which will be using these APACHE scores. The main advantage of APACHE-II scoring system is the immediate assessment of the severity of the pancreatitis. So you saw Ranson score which may be missing for 48 hours. So in between 48 hours, or if the patient presents after 48 hours, like 3-4 days, you don't have proper guidelines to which are those assessment markers for severity. So APACHE-II score is more helpful in this scenario. A score of 8 or more at admission is usually considered indicative of severe disease. So this is again a MCQ line. So APACHE-II score of more than 8, you should be taken as severe pancreatitis. So how do you treat pancreatitis? First you have to differentiate between mild, moderate and severe. Then you have to treat accordingly. The severity ranging from mild and self-limiting to the life-threatening necrotizing variety. Regardless of severity, hospitalization of the patient with suspected acute pancreatitis done for observation, and diagnostic study is usually mandatory. So all patients which will be subjected to the admissions, they should be evaluated thoroughly. Upon confirmation of diagnosis, patients with moderate to severe disease should be transferred to intensive care unit for observation and maximal support. So if the patient has got tachycardia, maybe in shock, or patient may be having fever, all these patients should be transferred to intensive care unit. The most important initial treatment is conservative intensive care. So all the patients of acute pancreatitis should be conserved for initially 3 weeks. So try to push all things to the end of 3 weeks, then you will get maximum good results of acute pancreatitis. So you have to monitor with goals of oral food and fluid restriction. So you should not give orally anything. Then replacement of fluids and electrolytes parenterally as assessed by central venous pressure, along with monitoring of urinary output, and you have to control pain adequately. So here the morphine is not given. So if you are got question which of the following analgesics is not given in acute pancreatitis, it is morphine based. So morphine will induce spasm of sphincter of Oda and it will aggravate the pancreatitis. In severe acute pancreatitis, or when signs of infection are present, most experts recommend broad spectrum antibiotics, so which is imipenem. So whenever you have got raised WBC counts and patient is in shock, it is the imipenem, the choice of antibiotic, because it has got the highest level of concentrations achieved in pancreatic parenchyma. So if you have got question which of the following antibiotics which you will be using, or they may be giving you clinical scenario where the patient has got shock, raised WBD counts may be more than 20,000. So you have to pick up antibiotics which is imipenem. There should be careful surveillance for the complication of disease in severe acute pancreatitis. So how do you treat mild pancreatitis? The current principles of treatment are physiologic monitoring, metabolic support and fluid balance, which can become dangerously disturbed even in mild acute pancreatitis because of fluid sequestration and persistent vomiting. Because of hypovolemia, which may result in pancreatic and other visceral ischemia, fluid balance should be assessed every 8 hourly. Severe pancreatitis, the pancreatitis can be classified on the based on APACHE-II and Ranson signs. So all these patients who will fit in severe pancreatitis, so elderly patients with 3 or more Ranson criteria should be monitored carefully despite the absence of severe pain. And these patients are more likely to go in ARDS, that is they may have got lung complications of pancreatitis. So the next serious complication of pancreatitis is infection. So it is the most common cause of death. So if you have got a MCQ question, which is the most common cause of death in acute pancreatitis is infection. It is not because of hemorrhage or not because of other causes. It is only sepsis. It is caused most often by translocated enteric bacteria and is seen commonly in necrotizing rather than interstitial pancreatitis. So all the pancreas is covered with large bowel, small bowel, stomach and duodenum. So whenever there is translocation of bacteria across the inflamed gut, which is sterile necrosis, which is there after pancreatitis, can get infected, and this causes air information in the CT scan, which is detected on CT scan. The beneficial prophylactic effect with antibiotics such as metronidazole, imipenem and third generation cephalosporin. So imipenem should be given in severe pancreatitis where you suspect infection. So pancreatic abscess occurs 2 to 6 weeks after the initial attack, in contrast to infected necrosis which occurs in first few hours or days. You should know difference between infected necrosis and pancreatic abscess. So you may be given a clinical scenario. So after say 2 weeks or 3 weeks, the patient presents with, they will give you various distension of abdomen, fever, and CT scan will show a collection. So which of the following things that you suspect? They will give you infected necrosis, they will give you pancreatic abscess and other distractors. So it is the pancreatic abscess which is there after 2 weeks. The mechanism of delayed infection is not clear, but the treatment consists of external drainage, whether established by surgical or by percutaneous catheter-based methods. The preliminary clinical trials on humans suggest that, on balance, the jejunal feeding may be superior to TPN. So all the patients which will have acute pancreatitis, once they start passing flatus and they have decreased amount of pain, you should start using gut. So the best method is to use jejunal feeding. So jejunal feeding will bypass the duodenum and all the pancreatic secretions and which will deliver food directly in the jejunum. So jejunal feeding is superior to the TPN. So we'll see now treatment of biliary pancreatitis. So biliary pancreatitis is rather a emergency situation where if treated adequately and obstruction is relieved, it will result in immediate improvement of the patient. The general consensus favors either urgent intervention, which is cholecystectomy, within the first 48 to 72 hours of admissions, or briefly delayed intervention after 72 hours but during initial hospitalization. So inflamed pancreas is given some time to recover and intervention is done. Cholecystectomy and operative common bile duct clearance is probably the best treatment for otherwise healthy patients with obstructive pancreatitis. However, patients who are at risk of surgical intervention are best treated by endoscopic sphincterotomy and clearance of stones by ERCP. So whenever possible, patient is treated with ERCP. Acute biliary pancreatitis, in which chemical studies suggest that obstruction persists after 24 hours of observation, emergency ERCP and stone extraction is indicated. So you are given a clinical scenario in which the biochemical markers such as alkaline phosphatase and bilirubin, which are elevated after 24 hours and patient has got acute pancreatitis. Which of the following will be the best investigation? So you have to first diagnose things by chemical analysis like bilirubin and alkaline phosphatase, and you have to subject these patients to therapeutic measures which is done by ERCP. So best methodology for management of biliary obstruction which is persist is ERCP. But routine ERCP for examination of bile duct is discouraged in cases of biliary pancreatitis, as the probability of finding residual stones is very low and the risk of ERCP induced pancreatitis is significant. Patients who are suspected of harboring persistent impacted stone in distal CBD or ampulla should have confirmation by radiologic imaging, CT or MRCP, or by endoscopic ultrasound before intervention. So whenever you are doubtful things with the mildly raised borderline enzyme levels but still you suspect biliary pancreatitis, so you should confirm things before undergoing ERCP. So friends, we saw acute pancreatitis. What are the causes? What are the complications? How do you treat acute pancreatitis? You can treat acute pancreatitis with adequate fluid supplementation and also various types of antibiotics. So we saw various types of acute grades of pancreatitis and their treatment. Thank you.